Hello everyone, this is Teach My Channel and I'm Sarah. In today's video, we will talk about the management of epithelial ovarian cancer. I'll share with you the basic approach. We know that ovarian cancer is usually aggressive cancer, diagnosed late, like in stage 3 or stage 4. However, in all ovarian cancer, we do surgery, and in most cases followed by chemotherapy. And here is the approach in 3 steps. You start with doing the surgery. And during the surgery, you will stage the disease. That is why it's called surgical staging. And then, after you send the specimen for pathological grading, you will decide whether you're going to put the patient on chemotherapy or not. If the patient presented in the early stage, and stage here means the clinical staging, then this is your approach. We agreed that all of them will undergo surgery and surgical staging. And chemotherapy here depends on your pathology grading. You did the surgery and found out the tumor is confined to ovaries. Then you only remove the tumor in the ovaries, and that's called stage 1. However, if it was outside the ovaries and limited to the pelvic area, this is stage 2. And you will do total abdominal hysterectomy, removal of uterus, bilateral or unilateral salpingo-oophorectomy, which means the removal of fallopian tube and the ovaries, either both sides or one side. You're going to do only one side if your choice of preserving fertility, in addition to doing infraomentectomy. If the patient presented in the late stage, we will approach aggressively. We will do surgery, as we said, and surgical staging, and always followed by chemotherapy. The surgery here is called cytoreduction, or debulking procedure if you ever heard about this. Simply, you will open the abdomen and remove all possible mass that you see. This is the cornerstone of therapy for ovarian cancer, but the question is, why you start with aggressive therapy? They found out that an optimal response is achieved following chemotherapy. It improves also the quality of life, and it improves the immune system, because usually ovarian cancer secretes cytokines, some of which are immunosuppressants. In cytoreduction, we use some terminologies like complete cytoreduction, optimal, and suboptimal. Complete cytoreduction means there is no grossly visible disease, and this is very difficult to achieve. Optimal means a residual disease that is less than or equal 1 centimeter in maximum tumor diameter. And this is what we always opt for. And suboptimal, tumor nodules that is more than 1 centimeter remaining. And here's the procedure. Usually, the majority of bulky disease is typically distributed in the pelvis, omentum, and right diaphragm, sometimes the spleen or the liver. So to achieve an optimal cytoreduction, you should consider doing diaphragmatic resection, and a very common complication is breaching the diaphragm, reaching the pleural cavity. You may consider doing splenectomy, and always followed by prophylactic vaccine. You may consider doing partial hepatectomy, but this is not an option if the liver disease is bulky or major vessels are involved. You may consider doing bowel resection, especially if there is obstruction. However, bowel resection is contraindicated if the patient is not stable or optimal cytoreduction cannot be achieved at other sites. And in this case, we will do bypass procedure. Bladder or ureter resections. This is rarely done, but we do it if the bladder or the ureters are involved. Systematic lymphadenectomy simply means that you remove all suspicious lymph node if possible. Lastly is the placement of a port for chemotherapy, to give an intraoperative chemotherapy, and we will see what this means. Lastly is chemotherapy. We will decide whether the patient is going to take chemotherapy or not after seeing the pathology result. Adjuvant chemotherapy, or the word adjuvant, means that the patient is receiving chemotherapy after the surgery. Ovarian cancer regimen is a platinum-based combination. So, in early stage, that is 1 or 2, we will not give chemotherapy if there is complete resected grade 1, stage 1A or 1B. However, you will give chemotherapy in high-risk features like stage 1C or 2, clear cell histology, or high tumor grade. On the other hand, late stage always receives chemotherapy. In optimal cytoreduction, you can only give IV chemotherapy, or you can add intraperitoneal chemotherapy. An example is HIPEC, which means heated intraperitoneal chemotherapy. Yes, we heat the chemotherapy. In suboptimal cytoreduction, they only consider IV chemotherapy. For some reason, the patient is not a candidate for surgery, then we will give neoadjuvant chemotherapy. The word neoadjuvant means you're giving chemotherapy before the surgery. Some reasons for not being a candidate is the location and volume of the disease, or sometimes comorbidities at the same time of diagnosis. And here's a summary from TeachMed.